Hi everyone, welcome to our webinar today. My name is Wang from the marketing department of YINGCHI company. It's my great honor to share with you the application of transcranial magnetic stimulation technique in Alzheimer's disease. And I'd like to invite you to follow us on below social platforms on which we will upload our excellent new products. And you can also find our newest academic webinars on this. Here, now let's begin. Now I post and here you can see a film poster. Yeah, and this is a famous film released in 2021, and this film has received universal acclaim and won several awards. Its depiction of experiencing dementia has probably had a reinforcing influence on most viewers' fearful perception of dementia. We can share the helpless and desperate feeling with both the father and the daughter. So what is dementia? Dementia, otherwise known as major neurocognitive disorder, according to DSM-5, it is not one specific disease, but rather a group of symptoms that happen because of a disease. Considerable cognitive decline compared to previous ability level in one or more cognitive areas, such as complex attention, executive function, learning and memory, language, perceptual, motor function, or social cognition, which interfere with one's activities of daily living and social autonomy. Now, among these, Alzheimer's disease is the most common cause of dementia in people over the age of 65. And Alzheimer's disease, here in after we call it AD. And AD is one of the most common neurodegenerative disorders, characterized by progressive decline in cognition, behavior, and activities of daily living. Alzheimer's disease has become a global serious medical issue. According to the data in 2018, there were 50 million AD patients worldwide, and there will be 152 million AD patients worldwide in 2050. And this problem is also very serious in China too. And besides this, Alzheimer's disease can bring a lot of pain to the patients, and it costs a lot. So the global cost of Alzheimer's disease accounts for approximately 1.09% of global GDP. The death, and besides this, AD is the 8th leading cause of death in China and the 6th leading cause of death in the United States. Deaths from Alzheimer's disease have increased 146% in the past 20 years. So what leads to this disease? There are many theories about this. And Alzheimer's disease is thought to be caused by the formation of abnormal deposition of protein in the brain. These are called plaques and tangles. And they are made of two proteins, beta amyloid and tau. Amyloid and tau are present in healthy brains too, but in Alzheimer's disease, they function abnormally. Beta amyloid forms plaques outside of cells, and tau forms tangles inside them. These plaques and tangles damage the nerve cells and causing them to die. When lots of cells die, this causes the brain to shrink. As more and more nerve cells die and more areas of the brain are affected, the symptoms of Alzheimer's disease become worse and numerous. This is sometimes known as gradual progression of symptoms. There are several risk factors that are related with this disease. And one of them is called non-interventional risk factors. And age is the biggest risk factors for AD. You can see that most AD patients start after 65 years of age. Besides this, you also can find men has a lower prevalence of dementia than women. In addition to age, the most clear risk factors for AD are genetic factors, which include the pathogenic genes of AD and the risk genes. Also, the risk of developing AD is influenced by the family history too. On the other hand, there are some intervenable risk factors which we can prevent in our normal life to reduce the risk to develop AD. And these risk factors contains the cardiovascular diseases, blood pressure, type 2 diabetes, and body mass, and so on. Next, we'll talk about the diagnosis and treatment of AD. Here we can find there have been many diagnosis criteria being published in the past years. And for the first one is published by the Alzheimer Association in 1984. And there's also the diagnosis criteria published by the American Psychiatric Association. These two criteria relies on the symptoms of this disease. And you can also find in many studies with TMS, these two criteria are used to select subjects. And there are also other criteria. One is the NIAAA. This is published by the National Institute of Aging and Alzheimer's Disease Association. And the other is published by the International Working Group. These two kinds of diagnostic criteria focus on the biomarkers of the disease. And they all recognize biomarker evidence of AD pathology exists in the absence of symptoms, whilst a definitive diagnosis of AD still requires pathological confirmation. Here we can see a progressive plot of Alzheimer's disease according to the NIAAA criteria published in 2011. This criteria emphasizes the continuity of the AD disease process. The current evidence suggests that amyloid biomarker may become abnormal anywhere from 10 to 20 years before noticeable clinical symptoms. And the biomarkers of neurodegeneration, here you can see the green line, become dynamic at a later point. And according to their criteria, AD is divided into three phases. The preclinical phase, which can tested by the biomarkers by using MRI, PET, or SF examination. And the MCI, also we call it mild cognitive impairment phase and dementia phase. Normally, when a patient go to the hospital for diagnosis, doctors will collect several aspects of information, and one is the medical history, and also they will do the physical examination, and also a lot of neuropsychological assessment. Then if a patient have cognitive function decline, they will also do other examination to find the type and cause of dementia. As Alzheimer disease has a very bad prognosis, many researchers and clinical workers are focusing on the early diagnosis of AD. So what's the point? And their studies can told us that patients that with MCI, especially MCI patients with memory impairment, has a higher rate to develop to AD than the healthy people. Yeah, so it's recommended to do neuropsychological test at the preliminary medical center to do the early diagnosis, and then we can take some measures to prevent the disease progress. Here we test some frequently used neuropsychological tests. There are two kinds of cognitive neuropsychological assessment. One is screening skills like the MSE, MOCA, ADS, COG, and the other kind of cognitive neuropsychological assessment includes some tests mainly for specific cognitive domain, like some connection tests, the number simple tests. And there are other questionnaires like the activities of daily living and the functional activities questionnaires, and also other questionnaires to assess the patient's emotional state. Except of tests, most researchers now focus on more quantitative methods to do the diagnosis. Because with questionnaires, the result is seriously influenced by the professional level of the doctors, and we can get, and also it's also influenced by the state of the patients at that day. So if we can use more quantitative and objective technique to do the diagnosis, maybe we can improve our efficient and also to do the to reduce the cost of the patients. And one technique is EEG. EEG methods is to use the electrophysiological indicators to record the brain activity. Now, when the brain is active, the post-synaptic potentials generated by a large number of neurons are formed after the summation. It records the electrical wave changes during brain activity and is the overall reflection of electrophysiological activities, a brain of cells on the cerebral cortex of skull surface. And the existing research results shows that based on the analysis of EEG characteristics, it has good sensitivity and specificity for the early auxiliary diagnosis of AD. In the early stage of AD, the EEG synchronization is weakened. The brain rhythm power value changes significantly, and the nonlinear dynamic characteristics are changed. All of these provide effective evaluation indicators for the early diagnosis of AD. As EEG device is also a cheap technique, it's easy to learn. Yeah, so it may has a high potential to promote it to more hospitals or clinics. Here we summarized some methods to analyze EEG data for the diagnosis of AD. So according to the World Alzheimer's report, it's recommended to do the imaging examination and the CSF examination. But these two kinds of techniques are very expensive. And for CSF, the cerebral spinal fluid test, because it's a relatively invasive test, many patients are not easy to accept it. Yeah. And so the neuropsychological test is easy to use, but the disadvantage of it is it's affected by the patient's education level, and also it's a subjective way to evaluate the degree of the cognitive decline. Yeah, and then the EEG technique may become a more promising technique. Yeah. Okay. So next we will look at the current methods to treat AD. Here we can see that there have been some medicines that are approved by different countries to treat AD, and but they mainly these drugs can be characterized to two kinds, and one is the acetylcholinesterase inhibitors, and the other kind is the AMD glutamate receptors blockers. Yeah, but the only approved intervention drugs has side effects and has very limited effectiveness in dose and duration. And of all reported AD drugs trials, 99.6% did not show measurable benefits compared to placebo. Now there's still no effective drug to prevent or delay dementia. Thus, many clinical workers turn to some non-drug techniques like the cognitive training or the TMS method. And as we have known that TMS is an invasive technique that normally we can know that it has different protocols, and single pulse TMS is often used to do the examination. For example, the motor evoked potentials, we can get the amplitude and latency of these potentials. And also we can get the motor threshold of a patient, which can be used to do the next clinical treatment. And also single pulse TMS can be combined with EEG. Yeah, that we can use the TMS evoked potentials to do more evaluation. And also paired pulse TMS is a very effective way to assess activation or inhibition of balance. And the frequently used indicators include the short intracortical inhibition, long intracortical inhibition, and the intracortical facilitation. And there are RTMS, the repetitive TMS, and the patent TMS are often used to do clinical treatment. And repetitive transcranial magnetic stimulation is often used to generate lasting effect. And RTMS involves strings of TMS pulses with various frequencies and intensities. It's a neurostimulation and neuromodulation method that generates long-lasting effects, including decreases cortical excitability for low frequencies and increases in cortical excitability for high frequencies. And during the past 2 decades, many basic and clinical studies have demonstrated that RTMS can ameliorate the symptoms of AD and has potential as a therapeutic method. The patent TMS can be used to assess brain plasticity levels. And it has 2 modes. The intermediate burst TMS can have excitable effect, and the continuous burst TMS have inhibitory effect. Both of these modes are used in clinical treatment too. Now, the mechanism of TMS is to affect the processing of information by the nervous system, including neuronal synaptic acceleration and inhibition, and the synaptic plasticity. The long-term potentiation and the long-term depression caused by the high and low frequency of TMS are important manifestations of the plasticity of synaptic function. And they are the main basis for TMS to treat different diseases with different frequencies. The TMS combining EEG can explore the cause-effect relationship between a specific brain area and the behavior or cognitive process. TMS provides a higher spatial resolution for EEG. And there are also imaging TMS EEG closed tube technique allows us to adjust the TMS parameter according to the real-time brain state by recording and analyzing the EEG data and extract certain EEG pattern after TMS, which may acquire a better treatment efficacy. Yeah, and besides the EEG, TMS is also can be used for diagnosis of AD. There are many indicators have been started in many papers published since past years. And among these, you can find that we can use single pulse TMS and also paired pulse TMS. And one finding is that with AD patients, their motor threshold is also influenced by the disease, and the AD patients with less severity have a higher motor threshold, but the AD patients with more serious symptoms, their motor threshold can decrease. And there's a very important finding that the SCI can distinguish frontotemporal dementia and the AD, and it has a sensitivity more than 90% and also a high specificity. Over the past decades, there have many studies that demonstrate the TMS efficacy in treatment in AD. And now here is a meta-analysis article that this includes a total of 12 studies with 231 patients, with 8 randomized controlled studies and 4 self-controlled studies. And the random effect analysis revealed that RTMS could significantly improve cognition compared to the sham RTMS group. And in her subgroup analysis, the effect for stimulation at a single target was 0.13. Now, which is higher, which is lower than the effect of multiple targets. And the treatment less than 3 sessions produced an effect of 0.29, whereas treatment for 5 or more sessions produced an effect of 2.77. Yeah, and the other interesting outcome is that combining RTMS with medication or cognitive training did not improve the outcome. Yeah, but this is different from other meta-analysis done before. But in this meta-analysis, RTMS combined with cognitive training have this tendency to have a higher effect size. And maybe RTMS combined with cognitive training may yield a greater enhancement, but it still needs more studies to demonstrate that. There's evidence-based guidelines published by the International Federal of Clinical Neurophysiology in 2019, and they found that now the mainly use the target for RTMS in treatment in AD is the dorsolateral prefrontal cortex and the precuneus, and also there's a promising protocol called multi-site RTMS combining with cognitive training. So while many studies are using DLPFC as the target, because DLPFC is functionally and structurally heterogeneous region of the brain and represents a key hub for episodic memory, executive functions, and reasoning. And the pathological changes and the dysfunction of the DLPFC are a hallmark feature of AD from its early stage. And DLPFC is also considered a key region contributing to several large-scale brain networks, such as the default mode network, the frontal parietal network, and the central executive network, whose alterations are associated with the clinical manifestations of AD. And the second target that are frequently mentioned is the precuneus. This is target at the parietal lobe and involved in episodic memory, visual spatial processing, and the various aspects of consciousness. probably through its engagement in large-scale neural networks, such as the default mode network and its strong connection with hippocampus. And in the guideline, multi-site RTMS commanding cognitive training has a level C recommendation. There have some good quality studies have demonstrated the efficacy of this protocol. This protocol can improve cognitive function, memory, and language level of AD patients, especially at mild or early stage of the disease. And this multi-site protocol includes the 6 brain areas, include Broca's areas, Wernicke's area, the right DRPFC, and the left DRPFC, and the bilateral parietal somatosensory association cortices. Now, in this protocol, there are also the related cognitive training tasks. These tasks are aiming at different brain areas. We will we will read it in the following research. Here we did a brief summarize of the research published in RTMS in AD. We can see from here that there are many studies that use the criteria, diagnosis criteria published by the Alzheimer's Association. And also DSM-4 criteria is also used here. From the summary of the studies, we can see that TMS can bring different benefits for AD patients. So what's the potential treatment mechanism of TMS? There are 4 theories. The one is that maybe TMS can improve the plasticity and the connectivity of the cerebral cortical neurons. Robust synaptic plasticity is critical for cognitive processes such as learning and memory, and impaired plasticity could be the final common neural physiological mechanism for cognitive deficits of AD. The synaptic dysfunction could lead to a vicious cycle of aberrant neuroplasticity and amyloid deposition, resulting in progression of AD. AD patients showed consistent long-term depression-like effects that were comparable to those obtained in healthy controls when submitted to 40 seconds of continuous TBS. And the second theory thinks that TMS may promote the cerebral cortex blood flow and the glucose metabolism. And imaging studies have shown that the cortical blood flow and the glucose metabolism in AD patients decreased. The TMS can increase the target cortical blood flow. And the third theory suggests that TMS may improve the cerebral cortex excitability. The excitability of the cerebral cortex in AD patients is reduced. The TMS low frequency stimulation can reduce the excitability of the cerebral cortex, and high frequency can increase the excitability of the cerebral cortex. And the fourth theory thinks that the modulation of brain networks disconnection is the mechanism of RTMS. And the high frequency RTMS acting on the precuneus can correct the functional connection of the frontal lobe in the middle of the default network area. This is a study published in 2018. And there's also a new study that says that the high frequency RTMS to the dorsolateral prefrontal cortex modulates electroencephalographic function connectivity while improving cognitive function in patients with AD. And increased beta connectivity may have an important mechanistic role in RTMS therapeutic effects. Next, we will look through two good quality articles that are published in the past years. And the first one is one study published in Brain Stimulation Journal. In this article, in this study, they include 50 patients with a diagnosis of amnestic MCI or a diagnosis of mild to moderate probable AD. And they randomly assign patients to two groups, and one group is cognitive training plus real RTMS, and the second group will accept cognitive training plus sham RTMS. And the inclusion criteria were MSE score greater or equal to 16, and a clinical dementia rating scale score ranging from 0.5 to 2, and age between 60 and 85 years. And the exclusive criteria were the presence of potentially confounding medical, neurological, or psychiatric conditions. And also some patients that that will come now to do the treatment that violate the contradiction of TMS. And we can see from the table 1 that for these two groups, their baseline demographic information, for example, the age, education, have no significant difference, and also for the baseline MSE or CDR score. Now we'll look at their study design. And this design is a randomized double-blind placebo-controlled design. And yeah, for the cognitive training combined real RTMS group, the subject number is 27, and for the control group, the subject number is 23. And both of the group will receive 4 weeks of daily sessions treatment, and the total session is 20. And normally they will accept the RTMS treatment at first, then they will do the cognitive training. They will do the baseline evaluation, and also before the treatment, and also will do the evaluation again after the treatment. And then when the all session is finished, and they will do a second follow-up, and we'll do the evaluation again. And the TMS protocol in the study are as below, and they use figure 8 coil, and the target is at the left dorsolateral prefrontal cortex. they didn't use the neuro navigation here, only just use the F3 point according to the international EEG montage. Yeah, and the frequency is a high frequency as 20 hertz, and then they will also use the intensity according to the subject's RMT, and the intensity is relative 100%. And for its train pulse, the duration is 2 seconds with the interval 28 seconds. And in each session, one patient will receive 2,000 pulses. And besides the RTMS, each patient will do the cognitive training task. And its training task is a face name associative memory training. Now, this training is mainly focused on the episodic memory, and especially on the face name associative memory. Now, each training session consisted in the learning phase, during which the patient had to memorize the association between faces and names, followed by a recognition phase, in which the patient had to identify the correct face for each displayed name. Depending on whether the patient succeeded or failed the task, the difficulty level was adjusted to meet the patient's capacity. And after this process was continuously repeated until the cognitive training session ended. The difficulty of the task was modulated by the number of face name associations to be learned. As the difficulty further increased, higher levels consisted in an increasing number of face name per session associations to be learned. Highest level difficulty levels consisted in an increasing number of face name profession phone number associations to be learned. And the researchers will record the final difficulty level the patients get at the end of all the treatment session. Now we'll look at the results of this study. In this study, they did another analysis, and the result showed that on the performance at the face name associative memory training showed a main effect of time. Yeah, there's a trend toward significance for treatment and a significant time treatment interaction. And the post-hoc comparisons reveal that the patients in the cognitive combining real TMS group showed a better face name associative memory performance at the T4 evaluation compared to patients in the cognitive training combining SAM RTMS group. Here. And the T4 evaluation is the evaluation after the TMS treatment immediately. And also there's the add-on effect of RTMS on face name memory was affected by the baseline cognitive status, and with less impaired patients showing a great advantage from the add-on RTMS treatment. And the add-on RTMS treatment efficacy is also influenced by the patient education level. And with more educated patients exhibit a higher a greater faceting memory amelioration induced by RTMS. And further analysis show that there's also main effects of time and treatment in the performance in the raven-colored progressive matrix task. This task is mainly used to assess patients' visual-spatial reasoning ability. And the post-hoc comparisons indicate that a greater improvement in this task at T4 evaluation after real RTMS as compared to sham RTMS group. And this greater improvement persists over the second follow-up assessment, which indicates a robust and long-lasting generalization of the add-on effect of RTMS at left dorsolateral prefrontal cortex to this cognitive function. But unfortunately, they didn't find other add-on RTMS effect on language, verbal, or visual-spatial long-term memory, attention, executive function, or emotion. We can get the conclusion from the study that RTMS can enhance the effect of face-name-associative memory cognitive training, and the add-on RTMS effect was influenced by disease severity and education, and this RTMS amelioration can be generalized to visual-spatial reasoning. And next, we will look through a second RCT study that is published in Alzheimer's and Dementia Journal. In this study, they did a multi-center study, which includes 129 subjects. And this is the inclusion criteria in this study. And we can also find from the table 1 here that there's the subjects are divided into 2 groups, and one is the active group. The active group will receive the real RTMS and the real cognitive training, and the sham group will accept the sham RTMS and the sham cognitive training tasks. And here's the study design. In this study, they specified or defined the endpoints as the mean change from baseline in the ADAS-COG and also the ADCS-CGIC score 1 and 6 weeks after the intervention. That is the week 7th and week 12th evaluation. And the total treatment includes the 6 weeks of intervention. And each week, they will do 5 days intervention. And after all the 6 weeks treatment, they will do a follow-up visit. Two follow-up visits. And in this study, they will also evaluate the safety of RTMS treatment in 80 patients. And if analyze if this side effects are related to the device. And they used the 58 coil too, and the TMS treatment protocol is the multi-site treatment, which includes 6 brain regions, that is the broadcast area, YINGCHI area, the bilateral dorsolateral prefrontal cortex, and the bilateral inferior parietal lobe. And the frequency is 10 Hz. Intensity is 110% of the patient's RMT. And the total pulse one session is 1,300. In the sham group, the same RTMS was delivered with a specially designed coil that created identical noise as real RTMS, but delivered no electromagnetic energy. And for the cognitive training task, these tasks were designed to engage the 6 targeted interesting regions. And in conjunction with the RTMS cortical stimulation, the patient performed the following tasks. For the Broca region, the patient will do the syntax and the grammar tasks. And for the YINGCHI regions, and they will do the comprehension of the lexical meaning and the categorization tasks. And for the DLPFC, they will do the spatial memory tasks. And for the inferior parietal lobe, they will do the spatial attention tasks. And to keep patient challenge, the difficult level of the tasks were also adapted according to the patient's performance. And for the control group, the participants were engaged in the visual perceptual task, which presented pictures of objects and required to report as like or dislike, and short nature movies without a demand for any response. Now there's a chart for the treatment procedure in this study. That is, they will do a baseline evaluation and also use these 2 frequently used questionnaires, and then the patients will receive 6 weeks treatment. And after the treatment, the researchers will do 2 follow-up. One is at the 7th week, and one is at the 12th week. Yeah, and now we will look through the results in this study. First of all, we will look at the safety issue. And according to the study's report, there are only a very mild and transient side effects of the patients. And no patient withdrew from the study due to the side effects. And for the treatment efficacy, here we can see that in the PO population, they didn't find any statistically significant difference on ADS-COG, the cognitive questionnaire between the active and the sham group at the 7th week. However, at the 12th week, the cognitive score was back to the baseline for the sham group, whereas the active group showed a sustained improvement. The P population here is the subgroup who received at least one active or sham treatment. And later, the researchers, they divide the participants into two groups. One is the patient whose cognitive score is below 30, is 30 or below 30. And one group is the patients whose cognitive score higher than 30. Because this questionnaire, in this questionnaire, the a high score means a higher score means more serious symptom. Yeah. So, and also there's some evidence that the patients with a lower cognitive score has significantly higher motor threshold values as compared with subjects with baseline cognitive score higher than 30. And yeah, that means the patients with mild system, yeah, they will receive a higher intensity treatment. So maybe they can get more benefits from the RTMS treatment. So, and also in this study, the patients with cognitive score lower than 30 is about 85% of the total study population. After they analyze the results of this subgroup, yeah, the group with mild symptoms. Yeah. And now we can see from this this chart that those in the active group, here we can see the purple line. Yeah, in the active group, the subjects experienced a mean age in the cognitive questionnaire score at 12th week of more than 22, and the equivalent subpopulation in the sham group showed a mean change of 20.32 score. Yeah. And the between group difference was statistically significant. And also in the PE population, the between group difference approached the statistical significance. And in the later response analysis, we can see that, and more about 30.7% participants are in the active group with 24-point improvement on the cognitive questionnaire versus 15.4% in the sham group. And for the other questionnaire, the clinical global impression change, we also can find that in the at week 7, the CGI-C scores were similar between groups, but at week 12, they were significantly different in favor of the active treatment. Because at the baseline, all the patients get a clinical global impression of a change score as a full score. So they will compare the later score with the full as a baseline. Now we can get the conclusion from this study that the neural AD therapy system, because in this study they use the therapy system produced by neural AD company, and that means the multi-site RTMS combining cognitive training protocol provides a low-risk therapeutic benefit for patients with mild AD beyond the pharmacologic SOC. Yeah, that is the standard care. And so this is the newly published articles about the RTMS application in AD. Okay. And besides of the prevalence of AD, there are also findings that indicate that the age of the onset of AD inclines to the young. Yet maybe normally we think that people older than 60 or 65 have a high risk of AD. Yeah, but now we find maybe sometimes some people with 50, they have these signs to develop to AD. And according to the Alzheimer's Society, they suggest some useful tips to prevent dementia and Alzheimer. And these tips includes do more exercise and eat well, and also keep a good habit and don't smoke and cut down on alcohol. And also do some exercise for your mind. You can do some numerical games to keep your mind active. And also a very important point is to do the physical checks and also the mental checks regularly at the primary medical center. Yeah, and yeah, that is to look after your health regularly. Okay, you can find more details about the Alzheimer's series, about its diagnosis and the treatment in their website. Okay, that's all for today's topics. Thank you.